we are going to talk about the benefits and harms of oxygen, and too much oxygen is bad. I like this figure. It's my favorite figure in medicine that shows you that we have in the air 150 millimeter G of PO2, and to make my mitochondria active, I need only few millimeter of oxygen. And this is at the level of the sea. And this, like this, oxygen is just life. And that's only what I can do for my patient with hypoxemia. However, hypoxia is quite natural response. And for example, for Hélène, we are very proud in France from Hélène, who is the youngest female climbing on Everest last month. If you climb on Everest, you are hypoxemic, and this is a natural response. By contrast, if you want to see in the nature hyperoxia, that's not natural, and you always need supplemental oxygen and human intervention. So never you can find hyperoxia in the nature. That's not a natural response. Hyperoxia is very toxic, and there is a direct pulmonary toxicity, and the denitrogenation can create atelectasis when you use FiO2. That can induce hypercapnia, that can induce proliferative retinopathy, that's toxic for the brain, and there is the generation of reactive oxygen species, which are deleterious for tissues, creating apoptosis and inflammation. So hyperoxia is very toxic, and oxygen at high level is toxic. If I ask you if you control very well the oxygen delivery in your patient and the number of patients with hyperoxia in your unit, probably you don't tell me the truth. But in practice, that has been assessed in this exploratory study, and Douin and collaborator found that 46% of patients, and that's a large database of patients, 46% were hyperoxic. And hyperoxia was defined by an SiO2 above 96%. So that's a huge number of patients. Hyperoxia and outcome, hyperoxia is bad for outcome, and when you have study comparing normoxia and hyperoxia, and I show you here a meta-analysis, there is a very strong signal favoring normoxia as compared with hyperoxia. The most representative study, and that has been shown by Leone previously, is it's this Italian study, oxygen therapy, with comparing conservative versus conventional oxygen therapy. And which is interesting is that more than 30% of patients, around 40%, had PaO2 above 124. So that's really a liberal mode with high PaO2. And in this study, there is an increased mortality in the patient with liberal use of oxygen. But there is some conflicting results, which has been published recently, and there is 3 randomized controlled trial. There is the ICU ROCKS by the Australian and New Zealand groups. There is the French study comparing the liberal or conservative oxygen in IRDS, and a Scandinavian study. And all these studies were negative. And in fact, in this study, when you look at the study, which is important is the difference between the intervention group and the control group. And in this study, if you have a liberal group, a control group, which is really liberal, like in the Gerardis study with IPO2, there is an effect. But if your control group has a very limited amount of oxygen with a PO2 between 90 and 110, like in the ICU rocks or in the French study, probably there is no effect because you compare a conservative strategy and an ultra conservative strategy somewhere, and this is not the goal. There is also conflicting results coming from observational studies, and we have to be very prudent with observational studies. That's just a basis for future randomized clinical trial. But in all these in all these observational studies, that was trauma patients, chest trauma or severe trauma or traumatic brain injury, and the management of patient with oxygen was at the onset of the management during the first hours. So perhaps in the patient with severe shock, with severe bleeding, with severe traumatic injuries, in the early hour, but only in the early hour, there is something to assess, and we need more data about that. I'm very not sure that these results are very conclusive, but I think there is some room for improvement for this patient. So my take-home message: hyperoxia is a silent killer, and we should be very pay attention to this. There is a question for me for the short and early management of oxygen therapy in specific patients, especially patients with trauma, but that's just at the beginning of the management. And just remember the U curve, with hypoxia, which is a killer, and hyperoxia, which is also a killer. And the good target is probably between 70 and 110. Thank you for your attention.